Welcome to Part 2 of Region 11, Continuing Education. In Part 2, we will discuss a normal pregnancy, emergency delivery and newborn care, and newborn care resuscitation. A good place to start regarding the care of the newly born is to find out what you already know. What is the bag valve mask ventilation rate for the newly born? What do you do if you see meconium when the water bag breaks? Running away is not an option. What's the average length of time for cord pulsations to stop? What's considered a normal blood loss for a vaginal birth? In what stage of labor is the baby delivered? What newborn vital sign is most quickly influenced by ventilation? What is the compression to ventilation ratio in the newly born? What are 3 signs of imminent delivery? And where do OB patients over 20 weeks gestation get transported from the field? If you don't already know the answer to all of these, you will by the time we're through with your Con Ed. In our Region 11 system, we have 25 hospitals that have OB capabilities and only 7 that do not accept obstetrical emergencies. It's easier to remember those that do not. Weiss, Comer, Community First, previously known as Our Lady of Resurrection, Loretto, Lurie Children's, Thorek, and South Shore. If indeed you have ever presented with a pregnant person, this is probably the nurse that met you at the door. They do not have the capabilities, they do not have obstetricians on staff, and will be very unhappy to see you. And you'll probably hear from your employer as well as to why the patient went there. All right, so now that we know where not to take them, let's talk about some findings that are normal in pregnancy. Mom's stroke volume increases by 30%. Her heart rate increases anywhere between 15 and 20 beats per minute. Cardiac output increases 30 to 40%. Systemic vascular resistance decreases somewhere between 5 and 15%. Peripheral vasodilation is due to the hormone progesterone. It's also a smooth muscle relaxant that prevents premature uterine contractions, but also causes the vasodilation that lowers the blood pressure. Systolic blood pressure will be about 10 millimeters of mercury lower in the second trimester, diastolic about 15 millimeters lower. Blood pressure usually returns to normal in about week 36. All right, as we discussed on the previous slide, cardiac output for mom increases by 30 to 40%. Cardiac output has to increase to keep up with the extra blood volume, which has increased 35 to 50%. So normally, mom walks around with 5 to 6 liters. In her pregnancy, she may be carrying 7 to 9 liters. This extra volume is needed to fill the utero-placental fetal vasculature. Blood pressure will fluctuate throughout the trimesters. We talked about the heart rate increasing some 15 to 20 beats per minute over the baseline. But before the mom gets hypotensive, she's already had a major blood loss. The vessels that supply the uterus are low resistance and will readily vasoconstrict in an effort to shunt blood to the head, the heart, and the lungs at the expense of the uterus and the fetus. The body does not recognize the uterus as an organ that's necessary for life. If the mom has suffered a prolonged episode of hypotension, the fetus suffers from reduced oxygen. So don't wait until the mom is hypotensive. Give her high flow O2. Other changes, the output that she is carrying around, her plasma volume has increased by 40 to 50%. That's plasma volume. However, the RBC volume has only increased by about 20%. So this is referred to as a dilutional anemia, the anemia of pregnancy, more volume, but only half as many red blood cells. And if the oxygen rides on the red blood cell, then we do not have the oxygen carrying capability, which is one of the reasons we want all moms in distress on high flow O2. Some pulmonary changes. The diaphragm is elevated up to about 4 centimeters. Breathing seems to be more costal than abdominal. Most women become mouth breathers during pregnancy. There's an increase for their oxygen demand and consumption. Oxygen requirements, 10 to 20% increase. Residual volume has decreased. There's a greater risk for hypoxia and shortness of breath. Mom does not have the lung capacity that she used to. Therefore, she takes shorter breaths, more shallow breaths, so the rate increases by about 15%. There's some GI issues that the mother will have changes with as well. Esophageal sphincter tone relaxes, so reflux is much more common. And moms have been known to have a taste for all sorts of things that may not agree with them. There's a relaxation and a stretch of the abdominal wall. The farther along the pregnancy goes, the stomach and intestines are compressed and displaced upward. Mom will be prone to constipation and hemorrhoids, and gastric emptying is slowed. As stated before, always assume a full stomach in the pregnant patient. Other than that, hormones increase capillary permeability, which leads to edema of the hands and feet due to the sodium and water retention. For genitourinary, there's been an increased blood supply to the kidneys and the uterus, so they function well. The bladder usually is a pelvic organ, but becomes an abdominal organ at about 12 weeks because of displacement of the bladder from the growing uterus. And the pressure on the bladder will cause an increased urination. So if you've ever been out with a pregnant woman, you know that they tend to spend quite a bit of time going to the bathroom. There's also some musculoskeletal changes. Hormones produce a decrease in the strength of the ligaments that may predispose the patient to joint injury, especially back, pelvis, and the lower extremities. The pelvic floor muscles must carry the weight of the uterus, the amniotic fluid, and the fetus. Moms tend to have a shift in their posture as the center of gravity changes. In the third trimester, sometimes they can't see their feet, so they're more prone to falls, and they have the typical waddle gait. Any fall or injury that involves the pregnant abdomen can lead to partial abruptia, placental separation, and they should all be convinced to go to the hospital. When you look at these pictures, you can see the normal curves of the spine, normal lordosis and kyphosis. There's a slight pelvic tilt in early pregnancy. Normally, the center of gravity runs right through the center of the body. As the pregnancy advances, there's an increased pelvic tilt. There's an increased lordosis and kyphosis. The curves of the spine become more enhanced. The muscles are stretched and therefore weaker. They're tight, short muscles in the back, stretched and weakened muscles in the legs. The center of gravity has shifted, and there's tight, shortened muscle in the upper back. An issue specific to the pregnant mom is supine hypotensive syndrome. This can cause dizziness and a dramatic drop in blood pressure when the mom is lying flat, and the weight of the uterus, the infant, the placenta, and the amniotic fluid compress the inferior vena cava against her spine. This reduces the return of blood to the heart and reduces cardiac output, like a bowling ball sitting on a garden hose. This is why we ask you to place the moms on their left lateral to displace the weight off the vena cava. The weight of the uterus with the fluid, the breast, and the baby can be 20 pounds or better. So significant. Okay, so now you're aware of the emotional state and the hormonal imbalance of your pregnant loved one. So if she turns to you and asks this question, do I look fat? Before you answer, think about, there's 2 to 3 pounds for fluid volume, 3 to 4 pounds for blood volume, 1 to 2 pounds for breast enlargement, 2 pounds for the enlarged uterus, 2 pounds of amniotic fluid, 6 to 8 pounds for the baby, 1 to 2 pounds for the placenta, and 4 to 6 pounds for maternal fat and protein milk stores for breast production. Pregnant women retain about 6.5 liters of extra water during pregnancy. So prior to that answer, perhaps don't answer. All right, so let's take a call. We're minding our own business when dispatched for a 25-year-old female in active labor. The husband says, "Yes, doc, I think my wife is ready to have the baby. Our contradictions are only 30 seconds apart now." So is he going to take her by himself, or is he going to call 911? Probably better to call you. All right, what do I want to know from this mom? I'm going to get my sample history as I do with every other patient so I can render the best care. I'm also going to get a prenatal history. Probably one of my first questions is going to be if indeed she had prenatal care. If she had prenatal care, she'll be able to tell me a lot about her pregnancy. Were there any complications that developed during the pregnancy? When is her due date? When did the pains start? How far apart are the pains, and how long do they last? The number of pregnancies, gravida. Number of infants carried to 20 weeks plus, live births. Number of miscarriages or abortions that were lost before 20 weeks gestation. Has she had previous C-sections? Does she know if she's carrying multiples? Has she used any drugs or alcohol? Did the water bag break or is it leaking? If it broke, what color is the fluid? Does she have any bleeding? What's the amount? Is it bright red or is it dark? Does she have the urge to push? In my sample history, if my mom has a history of hypertension, heart disease, seizures, or diabetes, they can all be exacerbated by the stress of the pregnancy. Some of these questions, as we said, will not be able to be answered if the moms had no prenatal, and you may be finding that out in your first assessment. Why do I have to get all that information? What difference does it make, as our friend Hillary would say? Any previous illness may be exacerbated by the stress of the pregnancy. Knowing that history can alert you to the possible problems. If the mom has a history of hypertension, is it from the pregnancy of eclampsia, or has she had it before? I would have to be worried about a stroke. If she has a cardiac history, will this extra volume put her into heart failure or pulmonary edema? If she has a seizure history, is it eclampsia from the pregnancy? If indeed she has a seizure, there'll be airway compromise. If she's hypoxic, the baby's hypoxic as well. And if she has a pre-existing diabetes or diabetes that came on with pregnancy, there's a potential for hypoglycemia for the mom and the baby. They're usually very big babies, may have shoulder dystocia, be a very difficult delivery, and an altered, depressed infant. So those are potentials for the mom. For the baby, hypoxic mom equals hypoxic baby equals difficult transition and probably will necessitate resuscitation. Well, if your mom doesn't know too much, if she's had prenatal care, she can probably tell you the number of weeks, days, perhaps hours. Ultrasounds are part of the routine pregnancy care now. A term pregnancy should last 40 weeks, about 9 months, or 3 trimesters of 13 weeks each. Any pregnancy less than 37 weeks is considered preterm. If she's unsure but knows her last normal menstrual period, you can calculate by subtracting 3 months and adding 7 days to the last normal menstrual period. So she's not sure when she's due, but she can tell you that her last period was December 18th of 2014. So let's figure out her due date. The 12th month of December, I'll subtract 3 months. The 18 days, I will add 7 days. So her new due date would be 9/25 of 15. And if today is the 24th, how do you feel about that baby arriving in town today? Good, because the baby's term. So that's a point for him. Very good. So we're going to go along with our history, and then we'll say, do you feel lucky? Here's your answers. Your patient saw the doctor last week. She had a urinary tract infection at 6 months. Hasn't had any complications. She's due in 1 week. She's a Gravida 2, Para 1, AB zeros. So she has 1 child. She knows how this goes. It's a single birth. She did not use alcohol or drugs during her pregnancy. Her bag of water did break and it was clear. Her pains are about every 5 minutes and they started 6 hours ago. Do you have a fear of complications here? Or do you think this may be a pretty standard birth, you won't have to do much but assist in the delivery? But if your patient answered this, she hasn't had any prenatal care for the last 2 months. She's had swelling of her feet and headaches for the last month. She's not due for another 6 weeks. She's a Gravida 5, Para 1, AB3. So she definitely has no difficulty getting pregnant, but does have difficulty holding a pregnancy. It's a single birth. She hasn't done any heroin since yesterday. Bag of water was an explosive rupture and it was green and it smelled. She wants to push and her pain started about an hour ago. So from that history, what's your potential for the second patient? She's probably preeclamptic, certainly has a potential for seizures. We've defined that she's already had problems carrying to term. For the baby who's premature, under the influence of heroin, coming through a meconium, and a potential for a prolapse cord because it was an explosive bag of water rupture, what are we going to do about that? So which patient would you prefer? You don't get to decide if you have a baby today. You get to decide which of these two you would prefer to assist. So a little information can give you a lot of preparation info. For this baby, I would be worried about seizures. I would worry about obviously the eclampsia, the seizures. The baby's going to have some respiratory depression. First of all, it's 6 weeks premature and more than likely under the influence of the heroin, if indeed he's able to maintain an airway because of the meconium. And she's ready to go. This one sounds like we're going to have it right here. Little information gives you lots of thought process. All right, what are the 3 stages of labor? First stage is dilation of the cervix. Has to go from a closed cervix to about 4.5 inches wide, from 0 centimeters to 10 centimeters. In the second stage, this is where the baby is born, the expulsion of the infant. And then the third stage of delivery of the labor is the delivery of the placenta. Talk a little bit about each one. Dilation stage begins with the onset of true labor, contractions, and ends with complete dilation and effacement of the cervix. We talked about dilation being the opening, effacement being the thinning. Dilation is the progressive stretching of the cervical opening from closed to 10 centimeters, about 4 inches. Stage 1 usually lasts 5 to 10 hours. The expulsion stage begins with complete dilation of the cervix and ends with delivery of the fetus. This is the most painful of the stages of labor. Contractions are very strong, occurring every 2 minutes and lasting for a minute or more. The urge to push or bear down begins. Membranes will rupture in this stage if they have not previously. Crowning during contractions is evident. Birth is imminent. Stage 2 can last anywhere between 50 to 60 minutes. Very painful stage. Your emergency childbirth SMO, routine care, get the history and document. Rectal pressure means the baby is advancing towards the birth canal. The contractions are less than or equal to 2 minutes apart. If the mom is uncomfortable and unable to ambulate, vaginal bleeding, ask about the bleeding. Is it spotting or is it bright red bleeding? There may be a placental issue there. If she has ruptured membranes, and she has that uncontrollable urge to push. If any of the above are present, you must check for crowning. If you check for crowning and you check during a contraction and you do not see crowning, then we're going to monitor, time the contractions, and be on our way to the OB center. If you do check for crowning and you see it, you must prepare for the birth. It's much safer to have the baby where you're at than risk birth in an ambulance where one person is driving and only one is caring for the patient in the back. Controlled delivery of the head with the palm of your hand. As I said, you're not pushing it back in. You're trying to control it from an explosive delivery. Your current SMOs say gently suction the mouth and nose as soon as the head is delivered. But the newer thought process is we will avoid suctioning unless the baby absolutely needs it when he starts breathing. So the new suggestion is to wipe mucus from the mouth and the nose as soon as the head is delivered, but no more suctioning on the perineum. Once the head is delivered, you're going to check for the nuchal cord. You're going to guide the head and neck downward as the anterior shoulder delivers. Once the anterior shoulder is out, you will support the baby and guide the head and neck upwards as the posterior shoulder delivers. After that, it's a pretty fast delivery. Gentle suction only if needed. If your baby's crying, if your baby does not have any airway issues, there's no need to suction. And you'll go to your postpartum care SMO. So for the imminent birth, rectal pressure, contractions less than or equal to 2 minutes apart, very uncomfortable, unable to ambulate, vaginal bleeding. Many times when the early labor starts, the mom will have what they call a bit of a bloody show. It's more spotting than it is actual bleeding. If she has bright red bleeding, then she's either torn or there may be a placental tissue. Ruptured membranes and the urge to push. Check for crowning during the contraction. If this is what you see, turn up the heat and prepare to deliver a baby. So what do you do to prepare? What do you need? You need your OB kit. You need your personal protection, sheets and towels, and again, turn up the heat. If you're comfortable, it's not hot enough. Where would you prefer to deliver this patient? In her home or in the ambulance? In her home is more controlled. Now, because this mom told us that she's already had, when the bag of water ruptured, it was green and nasty smelling, that's meconium stained. How do I know if I'll need to aspirate for meconium? You don't know until the child is delivered. It all depends on the infant's activity. But if you do need it, that's not the time to get it. You should prepare as soon as you see meconium in the bag of water. You get your laryngoscope, you get your blade, you get your meconium aspirator, you get a 3 and a 3.5 ET tube, and you get your bag valve mask. Smallest blade you have would be for the premature infant, and this one is 6 weeks premature. So the 00 blade, 0 to 1 for the term baby. Must have it out, be ready, be prepared.
In the weeks before birth, your body slows down production of the hormone progesterone while increasing production of other hormones, including prostaglandins, which soften the cervix, and oxytocin, which triggers the uterine muscles to contract. True labor contractions are rhythmic and painful and grow consistently stronger. As the long vertical muscle bands of the uterus tighten, they pull the cervix open. The strong muscles at the top of the uterus push down and release, guiding your baby toward the cervix. The mucus plug, a collection of thickened cervical mucus that sealed your cervix shut for 9 months, may be expelled days before or in the midst of labor. When the amniotic sac ruptures, your water has broken. It can feel like a trickle or a gush of fluid. Your cervix will begin opening and thinning, known as dilation and effacement. Once you reach about 4 centimeters, your body will move into active labor. In active labor, contractions become stronger and closer together. At 8 centimeters, you enter what many consider the most painful part of labor, transition. By 10 centimeters, you're fully dilated and may feel the urge to push. This is your signal that the second stage of labor has begun. Your baby will move down with each contraction. The 3 separate soft bones of his head will temporarily overlap so he can pass through the snug birth canal. Your baby's scalp will come into view. When the widest part of his head is visible, your baby is crowning. With several more pushes, your baby's face, shoulders, and body will emerge. In the third and final stage of labor, your placenta detaches and is expelled. With your baby's first breath, the incredible journey of birth is complete.
All right, so that was the virtual delivery. Now we'll have some further photos. This is where we talk about controlling the delivery of the head with the palm of your hand. Don't let the baby head pop right out. Once delivered, wipe the face and nose of secretions. Check for the cord around the neck. Then guide the head and neck downward to assist delivery of the anterior shoulder. As the baby comes out face down, he or she will make the turn on their own to either the left or the right. You do not have to assist in that. What they're doing is trying to get in position to get those shoulders through. Some of us think the biggest part of the baby is the head, but it's not. It's the shoulders. And they themselves will position them so they can get through the canal. We ask you to guide the head and neck up after the anterior shoulder is delivered, and then down to get the posterior shoulder. Make sure you support the body as it delivers, and hold on tight. Slippery when wet. Once they're out, we will start to dry and warm them. We'll keep the baby at the level of the vagina until the cord is cut, and we will cut the cord when it stops pulsating. You can let the mom know it's a boy or it's a girl. Looking for warmth if your baby starts crying right away. Does he have an airway obstruction? No. So it's unlikely that you'll need to do suctioning for the baby. All right, stage 3. The placental stage begins after the birth of the infant and ends with delivery of the placenta. It may deliver anywhere between 5 and 30 minutes. There will continue to be some vaginal discharge, referred to as lochia, blood, mucus, and placental tissue. If you have done your newborn care, you do not have to wait on scene for the placenta to deliver. If it delivers, please bring it to the hospital. Prior to going into this delivery, with the information I obtained from the second patient that we had, I already know that that baby has a potential for resuscitation. He's premature, lungs are not fully developed. The last thing to fully developed, the first thing they need when they get out. So his respiratory effort will not be as it should. Maternal health problems. Mom's got high blood pressure. She's on drugs. Any narcotic use for the mom translates to respiratory depression for the infant. He has to have oxygen coming in so he can make the physiologic changes we're going to discuss in the next minute or two. If it was multiples, they're usually not carried to term. It's double work, double equipment, respiratory depression because they'll be premature. And very often with multiples, one baby will be born normal, the second baby will be in a breech position. And there was meconium, so this baby may not even start to breathe. There's the big potential for airway obstruction. So now that I know all these risk factors, I will anticipate and prepare for the resuscitation by having the laryngoscope, the meconium suction aspirator, the ET tubes, my bag valve mask ready to go. Hopefully I won't need it, but I'm ready if I do, as opposed to waiting for the delivery then saying, well, I better get my equipment now. So again, will I need to resuscitate that baby? He's less than 37 weeks. I'm going to need to assist to ventilations. Mom used drugs or alcohol. Good potential for respiratory depression. So the date, the drugs, multiples. I don't even know on this particular patient. She says single, but I'm not real fond of what else she gave me in the history. I need more equipment. They're probably not term, so they may both be respiratory depressed, and one may be breech. The meconium stained fluid may cause an airway obstruction. I have to be ready to do deep suctioning with the meconium aspirator. It all depends on the baby's activity, but as stated, we won't know that until the baby's delivered. I have to be ready. Cannot stop the baby from coming, but with these 4 quick questions, you can anticipate the likelihood of the newborn needing some help transitioning. If the mother gives you, my baby is so many weeks, which is what most of them do once they've had ultrasound, they usually don't say 6 weeks anymore. They'll say, oh, 24 weeks, 5 days, whatever. Just wanted to put in some fetal development milestones for you. So you'll know if the mom says, I'm only 16 weeks pregnant, these are some visuals that you might have. In the embryonic stage, which is up to 8 weeks, fetal heart begins to beat around the 4th week. At 8 weeks, the body systems and structures are formed. Baby's about an inch. The fetal stage, 8 to 12 weeks, fetal heart tones are audible by a Doppler. Kidneys start to produce urine. The baby's about 8 centimeters, so maybe about 3.2 inches, and weighs about a little over an ounce. This is when the fetus is most vulnerable to toxins. So the first trimester, any physicians that your wife may see, your wife, girlfriend, whoever, they're very stingy with the medication because everything is crossed over to the placental barrier. At 16 weeks or 4 months, the sex can be determined visually. The baby starts the process of respiration, swallows the amniotic fluid, produces meconium, looks like a baby, although very thin. At 5 weeks, you can see on the left the limb buds, the eyes, the heart, the liver, and the start of all other organs have started to develop in the embryo, which is about 1 centimeter long. 14 weeks, a little over 3 months, growth and development. Now we're calling it a fetus. Continues during the 2nd trimester. This fetus is about 6 centimeters long. 20 weeks, so 5 months gestation. The fetus grows to about 30 centimeters, about 14 or 15 inches in length. The fetal stage now, 20 weeks. Fetal heart tones are audible with a stethoscope. The mom feels movement. The baby develops a schedule of sucking, kicking, sleeping. Hair, eyebrows, and eyelashes are present. About 8 inches and weighs about 1 pound. At 24 weeks, we have increased activity. They begin the respiratory movement. So they are inhaling, but they are inhaling the amniotic fluid, moving the water in and out of their lungs. When they're born, their lungs are full of fluid. Baby now is up to about 1 pound, 10 ounces, and 28 centimeters, just a little less than a foot. One of the youngest babies to survive was born in Florida at 21 weeks and 6 days. She was about 9.5 inches long and weighed less than 10 ounces. At 28 weeks, surfactant for lung function is forming. Eyes begin to open and close. Baby weighs between 2 and 3 pounds. 32 weeks. Bones are fully developed but soft and flexible. Subcutaneous fat is being deposited. Fingernails and toenails are present. Baby now weighs somewhere between 3 and 4 pounds. 38 to 40 weeks, considered full term. The baby fills the uterine cavity, and the baby starts to receive some of mom's maternal antibodies. All right, so now he's out, he's arrived. What do we do? Happy birthday. The newly born refers to the first few hours of life. The newborn, or neonate, refers to the first 28 days of life. The reason they refer to the newly born is this baby is having some physiologic changes that happen in the first few hours of life as he transitions from in utero, totally dependent on mom and the placenta, to extrauterine life where he has to make all his parts work. And those first few hours, first few minutes, may be shades of what's to come. All right, he's arrived. For your postpartum care, we will note the time of delivery, pediatric routine medical care, Keep the newborn level with mom's vagina until the cord is clamped. If you pick him up high to show him, baby's blood will go back to the placenta. If you keep him too low, the placenta will engorge the baby. So level until the cord has stopped pulsating and is clamped. Your current SMO says suction with the bulb syringe or meconium aspirator is indicated. We're going to put a little importance on when it's indicated. It's certainly not routine. Dry and wrap the baby in a blanket. Clamp the cord when it stops pulsating at 6 and 8 inches and cut between the clamps. If there's breakthrough bleeding, then clamp again. If in respiratory distress, you can suction with the bulb syringe and assist ventilations with a neonatal bag valve at 100% O2. And if you ask in the field, 100% O2 for most of us means 15 liters. That can be dangerous for the baby. Baby doesn't get an oxygen saturation of in the 90s until he's been on this planet for about 10 minutes. We'll discuss that a little further. We're going to talk about assessing the APGAR score at 1 minute and 5 minutes after birth. Facts. Most of your term newborns require no resuscitation beyond maintenance of temperature, suctioning of the airway, and mild stimulation. About 10% require some assistance to begin regular breathing. Less than 1% will need extensive resuscitation to survive. The incidence of complications will increase as the birth weight and gestational age decrease. At birth, newborns must make 3 major physiological adaptations necessary for survival outside the womb. They have to empty the fluid from their lungs and replace it with air. They will change their circulatory pattern. In utero, they're getting their oxygen from the mom's blood supply through the placenta. When they're on their own, they will have to change their circulatory pattern and go to the lungs and pick up their own oxygen. And they must maintain their body temperature. Ventilation and oxygenation is essential for these events to happen. As I said, before birth, all the oxygen used by the fetus is diffused across the placental membrane from mom to baby. Because of this, there's only a very small portion of fetal blood that passes through the lungs, because that's not where they get their oxygen. Once they're no longer connected to the placenta, they must depend on the lungs as their only oxygen source. So the first few breaths of life are extremely important to aid in their transition from intrauterine to extrauterine life. Our job is to try and make it easy for the baby to take those initial breaths by assuring a clear open airway and stimulation to wake the baby up. Ventilation, not necessarily oxygenation. Ventilation of the baby's lungs is the most important and effective action in neonatal resuscitation. All right. There's a couple of pictures. They all depict more or less the same thing. Some of them just show up a little better. And the top 3 across are the alveoli. You can see in the first one, it's filled with fetal lung fluid, amniotic fluid. As the baby takes in air, room air, the fluid starts to displace through the capillary beds. By the second and third breath, we're almost empty. So following birth, the lungs expand as they're filled with air. Fetal lung fluid gradually leaves the alveoli. At the same time the lungs are expanding and the fetal lung fluid is clearing, the arterioles in the lung begin to open, allowing a considerable increase in the amount of blood flow through the lungs. Pulmonary blood flow increases, and the blood that was previously diverted through the ductus arteriosus now flows through the lungs, through the pulmonary arteries that have opened up. and picks up the oxygen to transport it to tissues throughout the body. Soon there is no need for this diversion called the ductus arteriosus, and it eventually closes. Further pictures is the pulmonary transition. It will show you the fetal lung fluid being displaced by the first, second, third, and subsequent breaths. So we have empty alveoli now, full of air, not fluid. Constricted vessels before birth have opened up, and now we have pulmonary blood flow. Here's your fetal circulation. Placenta does the job of the liver, the lungs, and the kidneys. Like the pulmonary veins of the lungs, the umbilical vein carries oxygenated blood from mom, and the two umbilical arteries have the deoxygenated blood. Only 7% of blood flow goes to the lungs in utero, as we discussed, because that's not where the baby is getting his oxygen. He's getting it from mom. So you can see the ductus arteriosus shunts the blood away from the lungs. Don't go to pick up oxygen because we don't have any there. Go right through the ductus into the aorta. We'll pick up the blood that mom has delivered, and we will oxygenate all our other organs. So you see a ductus, a large ductus on top of the heart there going right into the aorta. After birth, now in the neonatal circulation, now about 50% pulmonary and 50% systemic. And as the relaxation of the pulmonary vessels happens, now the blood flow goes to the lungs to pick up. And the closing ductus kind of turns into a fibrous band. We don't need it to shunt anymore. So it eventually will close up, usually totally close within 48 hours. If it doesn't, there's a medical issue called a PDA, patent ductus arteriosus. If it does not close, there is a surgical intervention to close it, because now you have oxygenated and deoxygenated blood combining. And again, all you have to be cognizant of is open airway, help that baby get good ventilation in. Doesn't have to be high flow oxygen. Room air oxygen is enough. That's what most babies start with. All right. Well, sorry for those of you who are doing this at night. I hope you didn't wake anybody up with that. But is that a good sound or a bad sound? It's a wonderful sound. It tells you the airway's open. It tells you the baby's making good effort to breathe. And if I look at my baby, he has good muscle tone. All those give me great information that that baby is in the process of making a successful transition. So is he term? Yes. Breathing or crying? Yes. Good muscle tone? Yes. If answers are yes to all of these, keep that baby warm and dry. Continue your ongoing evaluation. But right now he's starting off wonderfully. This reference is something that's referred to as the inverted pyramid. It's used by your neonatologists and people who care for the newly born. It's suggested you can spend about 30 seconds on each step of the pyramid. So the first thing we're going to do is assess our baby's response to birth. Secondarily, make sure that we have a warm environment for this baby. He came from 98.6 degrees to whatever the temperature is where he delivers. Keep him warm. Position. Sometimes a little Trendelenburg to help with secretions. Clear the airway if needed. Stimulate to breathe by drying, and give oxygen if necessary. Spend about 30 seconds on this. Baby doesn't know the rules yet that he has to continue breathing on his own. And many times as you dry him, that will be enough stimulation. We're looking for the baby's heart rate to be probably somewhere 120 to 160. But we're definitely going to make a mark that should be over 100. If it's less than that, we have to start ventilating for him. So, if after 30 seconds of warming and stimulating him to breathe, your baby has a decreased respiratory effort or has a heart rate that's less than 100, we're going to help him clear the fluid out of his lungs. And we're going to establish effective ventilation with our bag valve mask, and give him positive pressure ventilations somewhere between 40 to 60 a minute. We'll do that for about 30 seconds. The first vital sign that should show an improvement is the heart rate. It's the vital sign that is most affected by ventilation. If the heart rate drops to less than 60, in spite of us giving him bag mask ventilations, we will provide chest compressions. And at the very bottom of the pyramid, if I have a clear airway, I'm ventilating my baby well, I'm providing chest compressions, and his heart rate still does not come up over 60, I will administer medications. And the go-to medication would be epinephrine. So we think of terms in 30-second intervals on each step of the pyramid, and for every intervention, we reassess. So we will follow the pyramid in neonatal resuscitation. The exception to the rule is for babies born through meconium. We already talked about providing the warm environment, positioning the baby to help drain secretions, wipe or suction secretions if needed, first the mouth, then the nose, and then stimulate by drying or flicking the soles of the feet. "90% of your newly born will respond to the stimulation." So position the head, remove any wet linen, dry him thoroughly. If indeed you're going to suction, be very careful that you don't advance it too far and cause bradycardia. M goes before N. You would suction the mouth first and then the nose. And then gentle stimulation by rubbing the back or flicking the soles of the feet. Position, dry, warm position, suction only if necessary, and stimulate to breathe. 90% of your babies will respond to this. The three things you're going to look for is the evaluation after each action is going to determine whether you need to do further intervention. Respirations means he's getting room air oxygen in. If he's ventilating well, his heart rate should rise. And if he's ventilating well and oxygenating well, then his color should be good. They're not born pink. They're kind of a dusky color. The more air they get, the pinker they become. So these are the three assessments that you're going to make. Is there good effort? That's like I say, when you hear a crying baby, it's good to hear. What's the heart rate? The heart rate is a solid number that can reflect how well your interventions are going. And then the color is the assessment of the oxygenation. Crying newborn is the goal. It tells you they're ventilating well, there's no airway obstruction, and the physiological changes are most likely proceeding. So we'll dry him and warm him immediately after delivery. Dry the head and body. Remove any wet coverings from the infant. Cover him with a dry blanket or towel. And cover the newborn's head. The head accounts for 20% of the newborn's body surface area. Positioning and suctioning. Vigorous, deep suctioning can cause a vagal response in the newborn that results in bradycardia, which is very detrimental in the newborn who is transitioning. You should wipe away secretions first with the towel or the gauze. Head to the side will promote drainage. Gentle suctioning, if there are a lot of secretions, mouth first and then the nose. It is no longer recommended to suction on the perineum. Wipe the face and then proceed with the delivery. And again, what you're looking at is the baby's heart rate. Stimulate by flicking the heel of the foot or rubbing the back. Much of the stimulation is achieved in the drying process while we dry and warm the baby. If the newborn doesn't respond after 30 seconds of stimulation, then they are having what we call an apnea episode. In the newborn, there's two types of apnea. There's primary apnea, where the perinatal stress results in an initial period of breathing, followed by no breathing, an apnea episode. Stimulation, such as drying, suctioning, or flicking the feet, will cause the baby to resume breathing. If the baby does not respond to stimulation and begin breathing, then he's likely in secondary apnea, and no amount of additional stimulation will help. So don't keep flicking the feet. Keep coming, keep coming, keep coming, baby. This newborn needs to be assisted with positive pressure ventilations before the heart rate falls and full resuscitation is needed. Positive pressure ventilations can almost guarantee you a rapid rise in the heart rate. So primary apnea, they're easily aroused with stimulation. Secondary apnea, no amount of stimulation will get them going again. So don't sit there and persist. Go ahead and start bagging. This is pretty much it in a nutshell as far as your babies go. We determine a vigorous baby versus a depressed infant. Vigorous baby will have a strong respiratory effort, will have good muscle tone, and carry a heart rate over 100. The depressed infant has depressed respiratory rate and or effort, poor muscle tone, he'll be kind of flappy and flaccid, and has a heart rate below 100. So for your vigorous baby, just keep me warm. For your depressed baby, breathe for me. Don't offer him supplemental, do it for him. Remember, they're trying to transition and get that fluid out of their lungs. If we have to go ahead and breathe for them, then that's what we'll do. Because by getting the fluid out of the lungs, we get the pulmonary vessels to open up, we get the ductus to close. All those physiologic happenings depend on how that baby's breathing is. So if he's not doing it on his own, your job is to help him. 2 heart rates to remember, 60 and 100. Rates less than 100, but over 60, need positive pressure ventilations. Rates less than 60 need cardiac compressions along with those ventilations. Rates over 100 usually indicate that resuscitation interventions have been successful and can probably be stopped. Just continue to monitor. So the 2 rates to remember, 60 and 100. All right, if you're going to bag your baby, we'll ask you to slightly extend the head on the neck. And truth be told, they don't have much of a neck. You're looking for the sniff position. Make sure you have the mask that's appropriate for you, this small mask. Position your hands in the EC clamp. There may not be enough room for you to get all your fingers on the mask. Maintain a good seal. Don't jam or push the mask down on the face. Try and bring the face into the mask. Don't rest your hands or fingers on the baby's eyes. That's also a vagal, that can stimulate a vagal response. And we're going to ventilate at 40 to 60 breaths per minute, starting with room air is fine. That's what they would be breathing if they were breathing on their own. Watch for gentle chest rise and reassess in 30 seconds. Assisted ventilations without compressions are going to go at a rate of 40 to 60 per minute. Now in this picture you can tell there's not a good seal because there's no hands on that mask that's covering the baby's face. If you remember, breathe 2, 3, breathe 2, 3, breathe 2, 3, breathe 2, 3, you will be at a rate of about 50. And they're little puffs of air. That bag is about 250 cc's, the newborn bag. The baby needs about 25 cc's, so about 1/10 of that bag is enough for him. And while you're bagging for the baby, your partner, we're asking him to monitor the heart rate. Once you get the heart rate over 100, we'll see if this baby's breathing on his own. If he is, we can stop ventilations. We will continue to monitor the heart rate and the respiratory effort and keep him warm. He may have just needed a couple of trials of ventilations to open the lungs up, get the fluid out, and make the transition. The best indication that you have a proper seal and the lungs are being adequately inflated is the rising heart rate with audible bilateral breath sounds. They said tidal volume for a newborn is about 4 to 6 cc's per kilo. Your average newborn is probably 3 to 4 cc's. 3 to 4 kilos. So anywhere between 10 to 25 cc's of the bag. If you get a little crazy because your adrenaline may be flowing and you squeeze too hard, then you have the potential to blow one of those lungs. Tidal volume is about 1/10 of the bag. This is what I was referring to. It seems a very busy slide. However, when your baby is first born, it takes about 5 to 10 minutes for the newborn to achieve oxygen sats above 90%. Therefore, it has been suggested that we initiate resuscitation with room air, as all your other newborns would do. If after 90 seconds of room air ventilations, the heart rate is still less than 60, we'll ask you to begin with a lower concentration of oxygen, maybe 5 liters, gradually rise to 10. Try and get away from starting immediately with the 15 liters, whereas this baby's only been on the planet for 3 minutes and we start to resuscitate him with 15 liters, his normal sat during normal transition would only be 70 to 75% now. So we say it's not until 5 minutes that they've reached 90, 10 minutes where they're better than 90. Pulse oximetry can be used on the newly born. We ask that you measure it on the right side, which is called the preductal side. Preductal sats measure the blood that is going to the baby's brain and his lungs prior to passing the ductus arteriosus, where it may be mixed with deoxygenated blood. So these sats are measured on the right hand is the same sat as the blood that perfuses the brain, the heart, and the vital organs. The right side gets the blood from the aorta before it reaches the ductus arteriosus. So you can initiate your bag valve ventilation with room air. And then if you're going to supply oxygen, because the heart rate is still low, start with 5 liters, gradually rise to 10. Primary measure of adequate initial ventilation is prompt improvement in the heart rate. Heart rate is the trigger vital sign to watch in your newly born. Crying is a wonderful thing, but the heart rate tells you what that crying is doing. So we've been ventilating for 30 seconds, and the heart rate has not improved, and now it's dropped to less than 60. We need to begin chest compressions along with our ventilations. And for the newborn, the newly born, the ratio is 3 compressions to 1 ventilation. In the hopes we'll get about 30 breaths and 90 compressions in each minute, 120 events per minute. This would be a 1, 2, 3 puff, 1, 2, 3 puff, 1, 2, 3 puff. Compress on the 1, 2, and 3, no compression on the puff. You can stop compressions when the heart rate's over 60, but continue positive pressure ventilation until the heart rate is over 100. And now we're on the 4th step of the pyramid. If your infant does not respond, then we'll go to medications for your ALS. Chest compressions, again, the ratio is 3 to 1. The preferred method is the thumb encirclement on the lower half of the sternum. Depending on where you're at, if you do the others, the 2 fingers mid-sternum, it's another option. But the preferred method is the thumb encirclement. Medications are indicated when the heart muscle has been deprived of oxygen so long that it won't contract effectively, even though an oxygen assist is now being delivered. Epinephrine may benefit these infants and stimulate some cardiac responses. Epinephrine given to the newly born will be the 1 to 10,000 concentration. Can be given down an ET tube, IV, or IO. The dose is 0.01 to 0.03 mg per kg. The volume you will draw up is 0.1 to 0.3 mLs per kilo. This can be repeated every 3 to 5 minutes as long as the heart rate remains below 60, with your CPR continuing. Higher doses of the epinephrine may cause the very fragile capillary beds in the brain to bleed. Another drug that is essential for brain function in the newborn is dextrose. Prolonged hypoglycemia may contribute to neurological dysfunction post-resuscitation. The very, very limited glycogen stores are used up quickly during perinatal stress. Dextrose is indicated for a glucose less than 40 millimeters per deciliter. You currently have the D25 that you would dilute down to half strength for a 12.5 solution, and you would give 1 to 2 cc's per kilo IV or IO. We'd check the glucose 20 minutes later. In the event, as has been discussed in our region, we may be changing to a 10% solution. And if and when we do that, the dose will be 2 cc's per kilo that we give to the newly born. All right, my baby's been on the planet for a minute. We're going to do an APGAR score. Your first minute on Earth, and we're already making you take a test. The APGAR enables rapid evaluation of the newborn's transition from intrauterine to extrauterine life. Again, physiologic changes that have to come through. We're just trying to see how the process is going for the infant. Cutting the cord, there's no rush. At birth, about 1/3 of the baby's blood volume is in the placental system, and the cord, 2/3 is in the baby. Waiting until the cord stops pulsating assures the baby gets their full count of red blood cells, stem cells, and immune cells. It's their blood to begin with. If the cord is pulsating, the placenta is delivering oxygen, nutrients, and increased blood volume to support the transition to life outside the womb. Pulsations usually stop within 3 to 5 minutes of birth. again, cutting that cord. The cord is the lifeline. The placenta is the life source. If there's no cord, there's no oxygen, no nutrients, no stem cells coming from mom. Ideally, we'd like the baby to be actively breathing on their own before the cord is cut. Here you see, it looks like this baby's color is still pretty cyanotic. He hasn't been warmed or dried yet, and they're cutting the cord. Whereas in the bottom right, you see a pink baby who's skin to skin with mom and pretty much already just chilling. He's gotten everything he's going to get out of mom. And then the other picture shows you where we place the clamps and cut them. APGAR scoring is done at 1 minute and 5 minutes. Perfect score is 10. If you have an infant who has an APGAR of 0 to 3, he's severely depressed. 4 to 6 is a moderately depressed infant. 7 to 10 usually reflects a baby who's making a healthy transition. When the score is less than 7, they suggest repeat scores done every 5 minutes for up to about 20 minutes. You'll get no points, up to 2 points for each of these parameters. Appearance, referring to the color. Pulse, grimace, gives us a bit of the neurological. Activity, and respiration. Like the Glasgow, it's better to know the score of each component rather than just the number. If you describe your infant and his activity, the ECRN should be able to figure out the score for you. Meconium. Nasty, nasty. But meconium does happen. It happens in about 12% of all deliveries. And despite immediate suctioning, where we were prepared, we knew it was coming, 20 to 30% have meconium deep in the trachea, indicating a high incidence of intrauterine aspiration, not just coming through the birth canal. It's more common in post-mature babies, 42 weeks plus gestation, rarely in preemies, but we'll never say never, it can happen anytime. Meconium aspiration syndrome occurs in about 6% of the babies who are born through meconium. It exhibits as respiratory distress, aspiration pneumonia, apnea episodes, a pneumothorax, sometimes a persistent pulmonary hypertension. 25 to 60% may wind up on ventilators. 5 to 12% may die from complications. So meconium is a big deal. And the best we can do to try and keep the baby from aspirating is to be prepared when that baby delivers. Our goal is to do endotracheal suctioning to remove any meconium prior to the baby making his first attempts at breathing. Here's an at-risk newborn that's covered with meconium. Not vigorous, don't see any movement there, poor tone, poor respiratory effort. Endotracheal intubation and deep suctioning are required. If you also look, you can see the cord is very dark, which leads us to believe that this baby was probably floating in meconium for a while. It didn't just happen during the birth process. So you have your meconium aspirator. You have ET tubes, 2.5, 3, 3.5. Your suction turned on anywhere from 80 to 100. Have the equipment ready as soon as you see the meconium colored fluid. Deep suctioning with the ET tube if the infant is depressed. If it's not a depressed infant, wipe off his face and start at the top of the pyramid. You won't know if you need to suction for meconium until the baby is out and you determine if he's vigorous or not vigorous. But have your stuff ready. That is not the time to say, well, we better go unpack it. The limp baby covered with meconium, resuscitator is preparing to perform endotracheal intubation and suctioning. have a little more movement there. This is what you're looking for anatomically. If you do not see anatomical landmarks, the arytenoids, then you're not going to be in the right place. So in that bottom right picture, you'll see the cords going through. To the left of that is just the esophagus. All right, so here's everybody. We have the laryngoscope in, we have the ET tube in, we have the meconium aspirator on the end, getting ready to hook up the suction tubing. We're going to suction on the way out while we occlude the port. We're not going to suction longer than 3 to 5 seconds as the tube is withdrawn. And here you start to see a little bit of flexion with the baby. So he doesn't like that, so that's a good sign. So no suction longer than 3 to 5 seconds as you withdraw the tube. If no meconium is recovered, do not go back for more. Monitor the heart rate. If you did get some meconium and the infant does not have profound bradycardia, less than 60, you can repeat the procedure with a clean ET tube. If you start your process and the baby's heartbeat drops to less than 60, we need to ventilate him instead of further suctioning. So I will have a meconium baby versus a baby that needs full resuscitation. Sometimes you'll see this afterwards, the stained umbilical cord and staining of the fingernails. These babies were floating in meconium fluid for a while prior to birth. Acrocyanosis is very common in the newly born. Cyanosis of the hands and feet, but the trunk and mucous membranes are pink. Supplemental oxygen is not required. It usually resolves within 24 to 48 hours. If it persists, the infant should be worked up for a cardiac anomaly. Central cyanosis, when you look at this baby, if we had sound, you would hear good sound. He's got activity, looks like he's got good respiratory effort, and yet he's staying cyanotic, central cyanosis. Possible heart defect. Good respiratory effort, supplemental O2, but color is not improving. We need to keep him warm, observe him. Any child that's born with a external anomaly like club feet or a cleft palate, many times there's a bit of a greater likelihood that they may have an internal anomaly as well. Central cyanosis. Prematurity is the single most common factor for respiratory distress and cyanosis in the neonate. It occurs more frequently in infants that weigh less than 1,200 grams or 2.5 pounds and are less than 30 weeks gestation. Some other risk factors for respiratory distress and cyanosis include hypothermia, hypoglycemia. Usually you'll see depressed activity, management considerations, open airway, good breathing rate. All right, we'll finish up with preemies. As we said before, one of the youngest to survive was 21 weeks and 6 days. She was 9.5 inches, less than 10 ounces. This is a picture of her next to a ballpoint pen. As a rule, babies less than 23 weeks are not considered viable. Preemie problems. Preemies have immature lungs with a low surfactant and may be difficult to ventilate. They are much more prone to injury from positive pressure ventilations, so go gentle. Weak chest muscles do not allow for effective breaths, and nervous system may not provide enough stimulation to breathe. Preemies have immature blood vessels in the brain that are prone to hemorrhage from rapid changes in CO2 levels, blood pressure, or rapid changes in blood volume to the brain. So don't put them Trendelenburg, handle them gently. Immature tissue damage more easily by excessive oxygen. They're vulnerable to a hyperoxic, too much oxygen, retinopathy of prematurity, and vision loss. So if you've ever heard of somebody going blind from too much oxygen, this is what they're referencing. They have thin skin and a large surface area, which leads to rapid heat loss. Immature immune systems increase the risk of infection. Increased risk of hypovolemic shock related to the small blood volume that they have. So for yourselves, handle the baby gently. Avoid Trendelenburg. Avoid using excessive pressure during your ventilations. Use a pulse ox to adjust ventilation and oxygenation concentrations gradually. Do not give rapid and fluid infusions. The surfactant starts to form at 28 weeks, 7 months, and they usually have enough by 36 weeks. It keeps the alveoli from collapsing and relieves surface tension. They can give it through an ET tube into the lungs after birth. We'll keep them warm, but no hot packs. They only have about as much volume as a can of pop, about 300 and some cc's. Independent, some may do well. Here's an at-risk newborn, but he has good tone. He's a little preterm, small for gestational age, however, tone is excellent. So this baby may be like 35, 36 weeks. Here you have the at-risk newborn that's a bit smaller, very poor tone, worse than one would anticipate simply from being born premature. Resuscitation is required. So you see this flaccid, bird-like. Extreme prematurity is defined as less than 23 weeks or weighing less than 400 grams. This extremely preterm baby is born cyanotic, poor muscle tone, and requires assisted ventilation. Probability of survival is very dim, but if there are any signs of life, we will ask you to attempt resuscitation. Heart rate is being determined by either palpating the base of the cord or listening to the chest. Endotracheal intubation is begun as somebody listens to the heart rate. Intubation we would not advocate for you. If you can just bag the baby, we'll be fine. The tube is held in place as positive pressure ventilation is provided. Likelihood of survival is dim. Likelihood of survival without neurological issue is almost impossible. However, that's not a call we would ask you to address out in the field. We bring the baby in, you do what you can, and then the neonatologist can discuss with the mom, which is another reason that we'll be taking these infants to a place with OB capabilities. So in summary, childbirth is a normal process. OB emergencies are fairly uncommon. Most parents have a plan and stick to it. However, when something goes wrong, they call you. All pregnant patients are at risk for developing complications. It's impossible to predict which ones will actually occur, but obtaining a good history will help identify those at risk. It's important to recognize complications and act accordingly. The majority of EMS responses for obstetric emergencies are to patients who did not seek prenatal care or those who wait until the last minute to call for help. You will barely have time to introduce yourself before presented with a second patient. The best way to care for the unborn baby is to take good care of the mom. Be prepared. 12 hours of labor. I'm going to hear about this for the rest of my life. Thank you. Have a good day.